Well, good afternoon and welcome. I am Sidney Smith from the University of North Carolina. I'm a cardiologist and a past president of the World Heart Federation, and I have a passion for cardiovascular rehabilitation. With me is Julie Redfern from Bond University, who shares the passion for cardiovascular rehabilitation and is the prime mover behind what we're going to discuss today. I also want to introduce Lana Respal. Lana is the kind of person that can make your dreams come true. I'll tell you that we met 1 year ago in London with the Global Forum, which Julie organized, and here it is. A whole roadmap is ready, assembled in about 2 months with very active participation. So what we're going to do today is talk a little bit about the key ideas in this roadmap. What's it all about? Can it work? Where are we headed? And to do that, we've got an excellent panel. We'll go down the way with questions in just a minute, but I'll turn it over to Julie to say a few words.
Yeah, thanks, Sid, and very exciting to be here. I guess just to give everyone a little bit more context after what Sid opened. So we recognise the need for kind of uniting globally around this area of cardiac rehabilitation and what are we going to do moving forward? What are we going to do with this, management strategy, which is a little bit short term and a little bit sort of narrow. So we want to kind of take it forward. Where's it going to go in the future? So we held a global forum. Many of you were there last year at the ESC in London. And it was an amazing day, and we really brainstormed what we could do in this space globally. And one of the things was to produce some work and to engage the World Heart Federation. Before that, we actually had a survey as well, and we collected from over 300 people some ideas and information. So from that, I'm very thankful for the World Heart Federation for actually taking on our request and our advocacy to support this area of cardiac rehabilitation. And Jagat Narula, the president, was very keen to support that. And with the help of Professor David Wood and Sidney Smith, we've brought it to reality. So here we go. We're going to discuss it today. Lana's got some copies of the summary. Probably worth saying that we will be publishing the roadmap as well. It's not actually getting published today. It's ready to be submitted to the journal. So that will be forthcoming. But over to you, Sid.
Thank you, Julie. And for our first question, we'll turn to Dr. Abraham Babu from the Manipal College of Health Professions. And our question for you is, we know that cardiovascular rehabilitation works. Why is it not used more frequently?
That's a fantastic question, Sid, and thanks for having me, Sid and Julie. Cardiac rehab, I think we see it everywhere, and we know that it is a class 1 indication. And when we look around, we find the reasons for not participation to be the same. It's either patients stay too far away from the center, it's too expensive, or it is just that people don't know enough. It's lack of awareness, either from the cardiologist side or from the patient side. And overcoming these challenges are sometimes a big dilemma, especially in low resource settings where access to medical care is priority over rehab. But if you were to look at it from a low resource settings, we've identified very specific barriers to cardiac rehab. And one revolves around the lack of competencies among healthcare professionals offering cardiac rehab. The other being that in many private hospitals, they don't see rehab as a return on investment. They see it as high cost, but rehab is not that expensive. So that becomes a major challenge. And another way to look at it is that rehab is never marketed the way it should be. You'd see hospitals putting up, especially in low middle income countries, you'll see hoardings of new cardiologists joining their centers. But you very rarely see them coming up with cardiac rehab as a major component. So the barriers are tremendous. And let's not forget that access for women-specific cardiac rehab programs is also a major challenge. So I think the challenges are numerous, and I think around the world they're all still pretty much the same, be it high resource or low resource.
Yeah, well, that's excellent. Now, from my standpoint, you talked about not funding. I have sort of a tough love answer to that in the United States. I don't think hospitals should be paid for doing cardiac surgery and putting in stents unless they provide cardiac rehabilitation, because that's what rounds the procedure out.
Yeah.
But I want to come back to you, and I'll be a little tough. We ask you for one thing. It's underused. So if you had to, what's your top one?
Oh, that's a big question. I would say the starting point would be around education and capacity building, and having a workforce that is trained to deliver cardiac rehab. And I would not say that it's only with the healthcare professionals, but how much of cardiology training or cardiac training, cardiac surgery training actually incorporates cardiac rehab into it. And I think the scope is humongous if you were to think about educating the healthcare community at large. So if I was to say that one single barrier, I would probably go with education.
Beautiful. I like your answer. I agree with you. Julie.
Oh gosh, you were nervous there, weren't you, Abraham?
I was.
Okay, one of the things I guess that's been really great, we've got 22 people on the writing group. We had about 50 at the Global Forum, and we've got 11 case studies going to be in the final document, and they're from all over the world, including really interesting case studies from Malawi, from China, Barbados, so you can see a bit more about that. Some of them are in the summary. But I guess, you know, the lower middle income countries, to build on what you just mentioned there with Sid, what do you think is one of the most practical ways in these lower middle income countries to actually expand it beyond the workforce training?
I think one of the main things to have is to have educational programs that are readily available. Various organizations, I represent the International Council for Cardiovascular Prevention and Rehab, and we run a cardiac rehab foundations program that's completely online, targeting healthcare providers at the low resource settings. And I think that provides a good base to start with. It is easily accessible, it's easily available. And the advantage being that it can be accessed by any healthcare provider. But we also know from case studies that there are specific countries that train, especially physiotherapists who run a lot of the cardiac rehab programs. It's embedded within their curriculum. So I think education goes a long way, especially within the allied health streams. But if we were to put it in, and if we have a national curriculum in different countries that works to standardize curriculum, I think having components of rehab into them will definitely help and would probably meet that need.
Yeah, okay. I mean, I think that's good. What if the governments of a country like India, what is the one thing they could invest in to try and help this cardiovascular rehabilitation space?
I think I would still
Education.
stick to education, and I think
Okay.
as far as India is concerned, we have national education policies in place and national medical councils, and our education is getting quite regulated these days. I think it's important for a voice to be there to advocate for rehab, and it specifically in cardiac rehab, but also across the broader medical community as well for rehabilitation at large.
One thing I want to go back to, which is important in this new roadmap, you represent the International Association for Cardiovascular Prevention and Rehabilitation.
That's right.
And the thinking that has begun is whether or not, why do we wait with rehabilitation to do it after a patient has a heart attack and survives or has revascularization? Is there a role for prevention and rehabilitation early? Are the two, your association seems to combine them.
Yep. And it definitely there is. Prevention always works, and we need to think about healthy lifestyle and healthy living initiatives when we think about preventing cardiovascular disease. And I think there is definitely a lot of room to go there.
So let's move to Dr. Dion Candelaria from the University of Sydney. Question we have is, what are the most promising hybrid cardiac tele approaches, and what evidence gaps remain on safety, adherence, and scalability? So we want to talk about hybrid cardiac.
Thank you very much, Julia and Sid, and thank you for World Heart Federation for having me. I guess this question follows nicely from Abraham's question of barriers, because telehealth and tele-rehab has been, I guess, accelerated during COVID, and a lot of the programs shifted quite quickly in response to COVID restrictions. But I guess I would say that the best approaches in tele-rehab or hybrid is one that combines the best of both worlds. I don't want to say that tele-rehab is the solution or the only solution to the underuse of cardiac rehabilitation, because you don't want to replace, we always say one size doesn't fit all, but you don't want to replace it with a new box where other people don't fit in that new box. So I guess if you are to design a hybrid or tele-rehab, there should be, I guess, an initial in-person assessment for the contact, and then followed by an ongoing support through virtual or remote methods, depending on what the patient, preference and capabilities. So this could be through a phone call, apps, digital trackers, but also there should be an option for the patient to come in for an in-person check if that human connection is important to them. So I guess what I'm saying is there should be a great deal of flexibility in our offerings and in our programmings to maximize reach and access.
Are you using any hybrid technology in Sydney in your program?
Yes, so some of the programs in Sydney after COVID kept a virtual way of delivering cardiac rehab, but the problem now is because a lot of the programs went back to in-person, delivering two models at the same time would have some restrictions in terms of service delivery. The programs are not staffed to deliver both models and to have that high degree of personalization in their program. So they are still in some ways very programmatic with a set number of sessions and set number of weeks rather than tailored to a specific person's preferences and needs.
How are you monitoring, or are you monitoring exercise?
So exercise monitoring are done by exercise physiologists, and it is done through an initial assessment. So monitored through an online video conferencing or a phone call check-in, and then the most common way is to have a final assessment where they get reassessed for their exercise capacity, for example.
Do you have the safety and adherence issues under control?
Yeah, I guess one of the gaps with tele-rehab is, we need more evidence on safety, especially with higher risk groups. Also with adherence, monitoring adherence, I guess, is a challenge for tele-rehab. That's why there is, I guess, a big role of activity trackers and apps so people can self-monitor their activity levels and their exercise, their nutrition. But again, that's not for everyone. The other gaps are, of course, digital literacy. You can't expect everyone to have a smartphone, stable internet, vision and hearing acuity to engage well. So these are the issues. And also, there's also that the scalability issues, because a lot of the studies are done within confined, funded trials, and I think we need more evidence on implementation in real-world settings. And I guess Abraham has done a lot of work in heart failure, I think, tele-rehab. So we need to build that evidence for us to be more confident in what we're delivering to our patients.
Do your payers have a set of issues that they want solved before they will reimburse you? Does the Australian government, or what are you up against?
I'm not too sure about how the payers operate, but I think it has been an ongoing battle with hospitals and healthcare systems to be able to deliver a more flexible way of cardiac rehabilitation, to reach more patients, to provide more access to patients, especially those living in rural and remote areas, for example.
Julie.
Okay, thanks, Dion. I mean, one of the big focus of the new roadmap is to actually be more person-centred and actually be more patient-centred and, you know, move forward from our very traditional structured approach. But Dion, also another focus is about the term rehabilitation and then the short-term sort of nature of that term, that one does a period of rehabilitation and then they're finished. And so we're really trying to push into this lifelong cardiovascular health concept. So just thinking about that, but also thinking about hybrid models, how does that sort of capitalise on that or sort of help us build that idea of lifelong cardiovascular health?
Good question. So I think the hybrid models or telehealth or virtual models provide us with opportunity to extend the rehab beyond what we know as a fixed cardiac rehabilitation program. I think there should be opportunities for, I guess, more long-term check-in. I believe some countries are doing that a bit more. 6-month follow-up, for example, 1-year follow-up, just to see where patients are at. And of course, you can't expect them to come in person after a year or so. I mean, you can, but it would be easier to do it virtually if the patient has that capacity to do so. And of course, again, apps and digital trackers.
And so building on that, what about the engagement? How do we keep people with heart disease engaged in their cardiovascular health?
Yeah, I guess...
in general, not just as a hybrid approach.
Yeah. Patients would engage with something where they see value in it. So wherever patients place value in, I think is where we need to capitalize. A lot of the time, that value is in, for example, the clinician relationship. I think the initial contact between the clinician and the patient is crucial. It's almost a contract where they kind of are accountable to the clinician and they make a promise. But also it could be the value of a peer support group. So they engage because they value being part of a group. It could be having autonomy on their own management through digital tools, for example. So I think digital technology has a place in engagement, but also definitely human connection is also very powerful.
Yeah, I mean, I think that's great. And I think, Sid, just to circle back to you before you ask Irene, you said to me only an hour ago that, you know, the power of the doctor saying you need to do this, whatever that is, I think is very powerful. Did you want to comment on that before you move to Irene?
This is an area that I can get very semi-ballistic on. It really bothers me.
I'd like to see you get semi-ballistic.
Yeah, as an interventionalist, the surgeon or interventionalist should stand at the bedside after completing the procedure and saying, this is the beginning of a pathway to cardiovascular health. But we haven't solved the problem until you go through cardiac rehabilitation and change the things that cause these blockages to be here. And if the physician says, I want you to do that, I mean, we have this in smoking cessation. We know the physician who says, I want you to stop smoking, that's a powerful motivator. I think we need the revascularization community to stand up and stand at the bedside and say, this is part of the procedure. We've done one part, and the rehabilitation, if we're going to call it that, is essential to have a really good result. So I am particularly interested in seeing if we can improve that approach. So I guess we need to go to Irene, who's been sitting here patiently, not sleeping, but listening. And I wonder, from your standpoint, and I'm sure you're involved in talking with patients about rehab. I know that you do a lot with rehab, but what strategies improve enrollment and completion? So how do you get them engaged, and how do you keep them engaged?
Yes.
So, firstly, thank you, Sid and Julie, for the opportunity to be part of this panel discussion. And I'm so excited because it is only a year to the day, practically, since we brought people together to discuss cardiac rehab and how we can put it on the national and international agenda. But the question you ask is really important, and this is what it boils down to: how can we engage patients? And that engagement has to start at the point of diagnosis. It has to start in hospital prior to discharge. And that comes back to some of what Dean has been alluding to around the importance of educating patients. And if we look at the data around why don't patients attend cardiac rehabilitation, often, very simply, it comes down to not being informed about cardiac rehabilitation, the services that are available to them, but also the benefits and also what to expect from cardiac rehabilitation. And certainly there's that perception that cardiac rehabilitation is a time-limited program, and that perception and that message isn't very helpful when we're trying to encourage patients to engage in cardiac rehabilitation. So the education piece is absolutely critical. Accompanying that is the endorsement by the cardiac rehabilitation, or by the cardiologist, by the cardiac surgeon as well. And that endorsement is highly valued by patients. So having that conversation at the point before, prior to, or ideally before they're discharged is essential. One of the really important strategies in terms of promoting referral and uptake to cardiac rehabilitation that we know is highly effective is actually automatic referral to cardiac rehabilitation. And I think we need to look at referral to cardiac rehabilitation as an opt-out rather than an opt-in. So we don't ask our patients about, would you like to take an antihypertensive medication? We prescribe them an antihypertensive medication. So we need to frame cardiac rehabilitation in the same way that this is part of your secondary prevention care. This is going to reduce your risk of ending back in hospital within the next year. And also, I think we need to look at how we're presenting cardiovascular disease, and this is about self-management for life. So it's not a one-off program. So automatic referral, ideally through electronic means, through electronic health records, highly efficacious. In many countries, electronic health records are not widely available. So in Ireland, at the moment, it's using the standard paper-based referral form. That's absolutely fine as long as it's integrated as part of a systematic referral process, and that it's standardized and that every single patient is automatically referred. Dean has spoken a lot about the importance of offering patients choice and how, where, and when they attend cardiac rehabilitation. And I think that's really important when it comes to increasing enrollment and uptake. So we are delivering today cardiac rehabilitation as it was delivered 60 years ago. We are offering people cardiac rehabilitation in hospitals 9 to 5. So it doesn't really, it hasn't evolved to the societal needs and to the health system evolutions that are currently happening now. So I think that's really important. And, it's fantastic to see the research that's happening around hybrid models and using digital health. And that's where the COVID pandemic has been hugely helpful. But underpinning all of this, unless we have programs to refer people to, unless we can provide access to programs and availability, none of these strategies are going to work. And we know that where we have high densities of cardiac rehabilitation programs, and I know the ICCPR have done a lot of work on this, as have other academic institutions, those centres are ones where cardiac rehabilitation is reimbursed through health policy. So this is really, really important.
Yeah, I agree. I also wonder, University of North Carolina, we are now visiting them at the bedside before they leave. You talked about the importance, and I wonder who's doing it. Are the nurses doing it? And you have a special nurse management team that sees them in the hospital. The cardiologist is coming by. I want you to understand, I want you to be involved. If you let these people get out of the hospital, then you run into all kinds of problems. Getting in touch with them, explaining it over the phone. How's this? Do you visit in Ireland in the hospital and engage them?
So it works in different ways in different hospitals. I mean, resourcing is a huge challenge, of course. So in the centre where I work, the cardiac rehabilitation nurse will visit the patient before they're discharged. Where that's not feasible, another member of the staff We'll inform the patient about the benefits of cardiac rehabilitation. We'll sit down and, we'll discuss as part of their overall, not just about cardiac rehabilitation, but about, I suppose, the importance of, secondary prevention in terms of medications, adherence to medication. But that is done by a member of staff. And I think it's important that we look at optimizing the roles of all staff who work in healthcare settings, because then we may miss patients if we think that's just the job of the cardiac rehabilitation nurse. So it's incumbent upon all of us as healthcare professionals, if we are working in the setting where the patient is admitted to, that we have that conversation.
Yeah, we did a study in China in 36 hospitals looking at how many of the nurses actually understood what was happening in rehabilitation. How many of them understood what the medications they were giving to the patients were doing. And we found that educating the staff that was caring for these patients at the time of discharge actually increased adherence to medication. Patients actually understood why they got these pills and what was going on. So I think that's important.
Yeah, and I guess as well, it is challenging because, and I think we have to accept it's challenging because you've only got a small window of opportunity. I mean, patients are spending less and less time in hospital, and an average stay in Ireland, for PCI would be 24 hours, 48 hours, absolutely maximum. And in our centre, because it's a super regional centre for cardiology services, many of these patients are only with us maybe for 6 or 8 hours, and then they're discharged back to the tertiary hospital where they were referred from. So, we really have to look at pragmatic solutions, and this is where we need to engage with staff on the ground and see, well, what's going to work, and this is where, context is really important.
Yeah, I see this. We are drawing a crowd here much larger than many of the earlier sessions. I'm going to give you a chance to get involved.
They're waiting to see you go ballistic, Sid.
So, yeah, right. It'll come. So, Julie, I think you're on with the next
Yeah, I mean, I'm going to give a little bit of a plug to the World Heart Federation and say, honestly, I can't thank the World Heart Federation enough for actually taking on this space that is often left out. And I think this is actually a really critical point for this area of cardiovascular health to have this roadmap coming out. I also want to give another plug to the World Heart Federation for the Emerging Leader Program, of which Abraham, myself and Irene are all previous completers of. And I think it's these kind of programs that build capacity to help deliver the leaders of the next generation. So that's my plugs before I'm going to go to Irene. One of the interesting things that came out of Barbados for me, I really like this model, it's actually not in this summary, but it will be in the main paper, was this hub and spoke approach where maybe some of these lower middle income countries, there might be a big central hub with a lot of trained, really quite specialised, well-trained staff and people, and then these satellite programs, out in the various communities that can check in and be supported by the big centres. So you see a bit more about that when we actually publish the bigger roadmap. But Irene, I think one of the things, and I think it really came through at the Global Forum, was this concept of unity and sort of this global advocacy and voice. I think having the meeting in London and having the roadmap, it gives a platform. It allows us to do this advocacy and having people like Sid, really speak out for some of these important areas. So I guess I have another question for you too, but that one first. What do you think about this kind of unity?
I mean, I think the strength is in unity, and there's no doubt about it. I mean, we've seen what we're seeing here today in terms of the roadmap summary is really reflective of when you have 40 different organisations come together in a room for a half a day, and this is what it results in. And if we are going to be successful in having cardiac rehabilitation, secondary prevention on the global cardiovascular agenda, we need to have unified action from all of the various different professional groups. So that includes patient organisations, it includes our cardiac societies, who are incredibly important in our professional associations because they have credibility in the space. They're seen as the professionals. They can lead on the guidelines. And we need to be working collectively together. And I think that's probably been one of maybe the challenges we've had in cardiac rehabilitation together, that we probably haven't been working in a united way, maybe as effectively and as efficiently as we could be.
Well, I think people are beavering away for 50 years, sort of doing the same thing. And, I've worked in cardiac rehabilitation myself. It's very enjoyable. We have a good time. The patients have a good time. But are we really challenging ourselves on what that's going to look like in the future? But I guess that leads then to sort of the final official question for you, and we'll be able to open up to the audience here. One of the things you've shared with me, Irene, is how you're doing things in Ireland, and I think that's a really important concept for you to share with the audience, because that's about thinking about the person beyond their cardiovascular disease or their cardiac as a person with cardiac condition, and thinking about all of the other aspects of their life and other chronic conditions. And if you want to share with the group a bit about what you're doing in Ireland and how kind of stepping outside the traditional comfort zone has actually opened more opportunity for cardiovascular health.
Yeah, of course, Julie. And I guess Ireland, like many countries around the world, we don't have a comprehensive cardiovascular health strategy. We were one of the first countries in Europe to develop one way back in 2002, but our most recent one expired in 2019. So in Ireland, we have had to really think differently about how we want to reframe and almost pitch cardiac rehabilitation against all of the other competing priorities in cardiology. So what we've been trying to do is leveraging existing health policy and trying to integrate cardiac rehabilitation as part of existing healthcare policy. And thankfully, we now have a new national policy which focuses on chronic disease management. So we have framed cardiac rehabilitation under the umbrella of chronic disease management. And there has been a huge emphasis in shifting care from the hospital to community. So what this looks like in practice is that we have 150 hubs, so one per 150,000 in the population across Ireland, that are delivering chronic disease. And when I say chronic disease, it includes cardiovascular disease, it includes respiratory disease and type 2 diabetes. And cardiac rehabilitation is one of those services that is delivered by a multidisciplinary team that includes a nurse specialist, dietitian, physiotherapist, supported by a psychologist, but importantly overseen by a cardiologist who has an integrated role between the hospital and the community. And what this means is when you have a conversation at the bedside is that you are now able to offer patients choice on the where, the when and the how they want to receive cardiac rehabilitation, so they can receive it in their local community or in their local hospital. And central to all of this is really about trying to provide equitable access to cardiac rehabilitation.
This sounds like a model program to me. I recall, if my memory's correct, Ireland was the first country in the European area to implement anti-smoking policies. So my hat's off to Ireland. You keep coming up and doing good things. And this sounds wonderful to me.
Well, no pressure. It's certainly early days, but it's a significant advancement, and I think the message here is really about how do you leverage existing policies within your own country, and how do you align cardiac rehabilitation to what are the priorities within your country, but also for us as an international group here today. And we know that we really should be positioning cardiac rehabilitation as a solution to achieving the UN sustainability goals, the 2030 goals. So, we have to be very strategic about how we're promoting cardiac rehabilitation and how we're framing it as well. And again, hugely important for the low to middle income countries.
So before we're going to turn this over to the audience, we have two experts sitting here, more than two, but I'd like to ask Dr. Larry Sperling just to say a few words. You have been involved at every level, community, at Emory, at the college, and nationally. I wonder if you'd say a few words about, and you've contributed to this work in editing and reviewing, where you think we're headed, and what are your ideas on cardiac rehab?
Yeah, thank you so much. First of all, I just want to congratulate this team and also add just thanks to the World Heart Federation for recognizing the importance of having a roadmap related to cardiac rehab. Also want to add my words of praise for Lana. She is really a force and such a great person to work with. Having been in this space now for 3 decades, and I most recently was Executive Director of the Million Hearts Initiative for the United States, so CDC, CMS initiative. You all are talking about really important concepts, but this must be a national priority, number one. There should be national strategy I heard the term value. And I think both patients, clinicians, and health systems really do not understand the value of cardiac rehabilitation, let alone what is cardiac rehabilitation. It is time to be bold and loving what is going on in Ireland, because I think an obstacle, and David Wood and I talked about this over a decade ago, is literally just the term exercise-based cardiac rehabilitation. So it's time to talk about the life course, and it can be cardiovascular disease prevention and risk reduction programs that are pan-vascular. Of course, we have heart failure, atrial fibrillation, on and on and on and on. And you can add and cardiac rehabilitation if you want to stay wedded to the term cardiac rehab. But patients, communities, clinicians, and health systems, they're going to understand that.
Yeah.
But I think after 60 years of doing the same thing and expecting the same different results, that's called insanity, Einstein described. It is time to use this roadmap as a jumping point to be bold and think towards the future.
Yeah, speaking about using and jumping, I'd like all in the audience to know, I'd like you to pick up the roadmap and implement it where you live, and then submit an abstract and take a trip to Rio de Janeiro, which is where we will be next year. We'd like to have a series of personal experience. It doesn't have to be totally finished. We'd like to have this group get together again and talk about where we are on the roadmap. And I could think of no better place than to do this and take a run on the beach than Rio de Janeiro. So, but I want to get to David Wood, he's another multi-decade friend. And I can remember discussing this issue in Atlanta, Georgia, walking back to the hotel. It must have been in the late 1990s. And that's when I first met David and learned of his intense interest, which he's followed through with in multiple trials. Could you make a few remarks, David, and let us share from your experience? And thank you again for your authorship in this paper.
Thank you, Sid, and congratulations to all of you. I really liked your question. If you had one choice, one thing you could do, and I think my choice would be to really empower patients to achieve lifelong cardiovascular health. I mean, I have given up on my interventional cardiology colleagues. I mean, they do a fantastic job, a life-saving job. But in clearing that clot and dilating that artery and inserting a stent, they have covered a tiny, tiny fraction of a ubiquitous disease. The atherosclerosis is everywhere. And so, of course, they need a comprehensive program to address cardiovascular risk as a whole. And I don't think that should be down to us as health professionals telling patients what to do. I think we should be empowering patients in this modern electronic age to address their own health and support them.
You know, I think that's true. All you have to do is to be a parent with a teenager to know that telling them to do something is exactly the opposite way to get them to do it. But I do think we have to get back to how do we empower patients in systems where they may not be reimbursed for going. How do we want them energized for sure. We want them pounding on the table. Where do we go with empowerment? Make it possible would be empowering them. Question in the back.
So, hi everyone, my name is Martha Galati. I do think one thing about the name, cardiac rehabilitation, needs to go away. I do think it needs to be called the Cardiac Recovery Program. I think that if we change that, language matters, and I think there's something about that word that doesn't resonate with patients, and I do think we need all to be sharing our strategies that do work. I think one thing, because of Larry, I was incentivized just by listening to him always to get our numbers to be better. And, I'm at a big hospital where only 9% of patients are even being referred, and yet we are a good hospital. We're considered one of the top hospitals, though. This should be a metric, I think, at least in the United States. It should represent value and good care. But I also think little things like we did with our electronic records, we've now made a simple prompt. It increased our referral rate at least now to 30%, and people don't just shut it off. Actually, we found more so than any other prompt that has appeared. So sharing with each other the ideas that work can also help, because I do think, as you said, that this is a universal problem that we're all trying to deal with.
Yeah, we call those BPAs in Epic, and we have that with ours. The problem is you can't let them off the hook because they've ordered cardiac rehab. The patient has to show up, and the true measure has to be patients appearing and participating in rehab, and we have to get that somehow. Yeah, in the back, please. Thank you very much, Martha.
Hi, thank you all very much for this very informative session, and really good to see you, David. Just exactly what Martha said, that was my first comment. We need to change the name because, when you think about cardiac rehab, two things it does. Number one, it makes even clinicians feel like patients who may not all need it. For instance, we almost never refer elective PCI patients to rehab. It's usually post-MI, right? So I think there's something about the nomenclature that has to be adapted to something else. That's one. Number two, I also think is the way it's framed. So for instance, in our hospital in Hamilton, Canada, we have automatic referrals to cardiac rehab. So the problem is not the referrals. We get the referrals, but the patients opt out because it's sort of framed as they want the the prevention clinic, but they don't want the exercise component because we're giving it as two different things, which I think is a mistake. It should be one comprehensive service, not hospital-based in terms of the clinical aspect, but like the physical aspect cannot be hospital-based. It's not sustainable. So I think it's also the framing of how we refer to cardiac rehab and how we think about it as we're very good with the prevention clinic. So all our patients come to the clinic to get their lipids measured, treated, glycemia, all these things. But the diet, the lifestyle, the smoking, all those things are sort of, they can opt out of that part. So how we sort of frame the whole concept of cardiac rehab, I think needs to sort of be modified. And as we're the Ireland model would be fantastic if every system could adopt that. But in the meantime, I think the framing is also very important. Thank you.
Yeah, the committee strongly agreed that this rehab idea needs to be broadened to achieving cardiovascular health, for sure. And again, the education, the reason I emphasize the physician, the surgeon who says nothing about this, or the cardiologist who does the procedure and says nothing, leaves the patient with the idea that it's all fixed. He didn't say anything, and he's the person, or she's the person that fixed my heart. So unless that segment of this procedure, if they stand forward and says, I've done my best, we've got a good result, but we've just started on getting you back to cardiovascular health. It's all it takes. They don't need to do it, just need to let the patient know that what has been done with the procedure does not completely solve the problem. I totally agree, and the rehab came up in our committee that trying to move beyond cardiovascular rehab, which sort of takes it out of exercise and nothing else, is really an important strategy. Julie.
Yeah, thanks, Sandra. One of the things, I guess, yes, we want to reframe the terminology. It's a bit difficult to kind of cut the word rehabilitation at this point completely, but we're hoping people can take this forward. The word cardiac in itself is a problem as well, so we've definitely changed to cardiovascular throughout the document. We have left the term rehabilitation, but we moved to this concept of lifelong cardiovascular health. So we'd be hoping the next steps are for people to implement this as a concept. So reframing, couldn't agree more. I guess I do just want to share something that I think is interesting from our cancer. We can learn from our colleagues that work in the area of cancer. Survivorship, which is not such a great term for us, but the concept of survivorship is everywhere, really well accepted, really well funded in cancer, really well accepted by patients, supporting patients for lifelong health who have survived cancer. And they have journals and everything around this idea. It almost doesn't exist in cardiovascular health. So I think whilst we may not use that term, I think we can learn a lot from those kind of ideas. Giuliano?
Well, first of all, I would like to say that it's a real honor being here participating on this session. It's amazing what we are achieving here. But the point is, I would like to share to all of you and hear your opinions about an important point in Brazil and also, I think, all over the world. The things that we don't have money enough to pay for the treatments that are happening now with the population which are getting the heart disease, the coronary disease, the stenting thing, the heart surgery thing is really, really not easy to be paid for the health insurance companies. And if we start looking for the prevention thing, as Professor Smith pointed, that when the companies start looking for the patient who pays them for their insurance and says, if you exercise, you will receive a kind of discount or something like that. That's a way to mobilize people to go to the rehabilitation programs. You know, if you move on their pockets and say, you should pay less if you move more, then the people who are referred to the cardiac rehabilitation would think twice before deny it, because they are receiving some kind of benefit. That's what I would like to hear from all of you. How do you think of this situation? Because I think if we move our looking for the money thing, the health insurance companies would understand that prevention is the way, and if they start charging less from the patient and starting benefiting them, we would reach something. How do you see this, Professor?
Yeah, I like your idea. I've had a chance to write some papers, do some studies in Brazil. My understanding about Brazil is that about 85% of the patients are covered by SUS, S-U-S, which is a government-sponsored insurance. It would be very easy for us to talk with SUS about a program that paid patients who got involved in rehabilitation and another group that didn't, and just see what those outcomes would be. They might find that it would work, and that the outcomes would actually reduce cost of care because the patients would not be readmitted. It's going to be out over a few years. They might have better results. So getting the patient involved somehow, paying them for doing it, it's not maybe my favorite approach is to tell hospitals we're not going to pay them for doing the procedures unless the patients get into rehab. That's my tough love. You know, you want to be in this program, you want to do surgery, we want the rehabs running and the patients enrolled.
I think sorry, you're going ballistic.
I think one of
the things that we haven't done very well as a community is actually have data and collect data in the very systematic ways, like our colleagues. As soon as a patient is having a PCI, there's streams of data collected about that person. It's pulled together within a hospital, within a state, within a country, within the world, and advocated for more service and more funding. And I think whilst we've been writing on pieces of paper, as you sort of said, I mean, we've done some research in Australia and we find a lot of our programs are still writing on a piece of paper. Oh yes, but we scan it and then it goes in the medical records. And so we can't compete with the big funding and processes happening around the world in the other areas of cardiovascular health unless we are able to start having some of these systems and sharing and collating some of this data. And maybe some of the things like you're doing, Irene, will help that. But I think data is a real powerful advocacy tool that we've been completely missing.
I fully agree, and just on that, the NIPC are just about to publish a paper on the back of the Interspar survey, which was conducted in 14 different countries across 6 different WHO regions, and where we've looked at cardiac rehabilitation and participation, and and again, it provides us really important insights into what's happening, the most contemporary insights in terms of what's happening in countries, but the data from those insights are not telling us anything new. They're so consistent with previous surveys. But when we're having the conversation about, how do we promote uptake and enrollment to cardiac rehabilitation in patients, I think we have to look at the solutions, but we have to look at groups of patients that we haven't actually been able to successfully crack the solutions for. So underrepresented populations, certain ethnic minority groups, older patients, women in particular, where there's very low rates of participation in cardiac rehabilitation on. So, Gilliana, thinking of, some of the stuff you're saying, there is some growing evidence about, using financial incentives to promote referral, but we also need to look at, how are we tailoring these programs to meet those needs? But we have to talk to these populations, and we have to involve these populations and engage them in how we're developing our services within our communities and within our hospitals, and involve patients in that very early stages. So when we have an opportunity to influence policy, that we're coming to the policymakers with the options that meet patient needs. So addressing patient need is critical.
Speaking of that, I just wonder if you and David and Catriona in Ireland, is it such that you could look at the system? Is it affecting all patients there? Could you present some data next year on how the Irish system is working?
We absolutely could present data, and we replicated the Eurospar survey in Ireland about 4 years ago, and the data is abysmal. And it's no different to any other country. I mean, access to cardiac rehabilitation varies from 4% to 97%, depending on what part of the country you live in. So there's a real lack of standardization. But there was a really interesting point that Martha mentioned earlier. We do need to be sharing our solutions and what we're doing. So hearing more about the digital work and how we can work more collectively together. And I think this is now about solutions. We've lots of data, but what are we doing with the data, and how are we addressing that disconnect between the evidence and practice and policy?
I think the one thing that I'll add to that fantastic answer, Irene, is unity. One is unity. We're working together, sharing our experiences, but at the same time, it's very important for us to have national leaders who know the context of each country and the nuances that each health system has, because you could put a lot of experts together, but it doesn't necessarily mean that one solution effective in Ireland is going to be effective in Brazil, is going to be effective in other countries. So I guess sharing learnings and getting, some principles that are potentially going to work in your context and adapting it and making it work in the health system you're in, I think that's what matters more, I think.
And also perhaps
Abraham.
the priority of where rehab stands. So low middle income countries, rehab is still not high on the priority. I think infectious diseases still take major priority there. So how do you compete with that? And probably one way is to piggyback on existing programs that are there. But we also need to be cognizant of the fact that those non-physician healthcare workers are already taxed beyond what they can do. And you burden them again with rehab on top of that, you're really stressing the system. So I think it needs to be adapted, definitely. And I completely agree that the availability of rehab centers is something, and it has to be contextualized to each country. So India, for example, in our ICCPR roles survey done in 2017, we found that we needed 3.3 million more centers to cater to the burden of ischemic heart disease at that time. And you can just imagine what it's going to be now. The new survey is going to show us an even bigger gap.
Yeah, that's why I want to harness the energy that's here today and see if we can get a few projects done and presented in Rio de Janeiro. Come back with because
you just want to go to Rio, Sid, right? You want to go to the beach, huh?
I won't turn down the trip, but I do think you've got the press there. I mean, this is a world congress, and press is there, and they're looking for things that are interesting, novel strategies that are working in Ireland, things that are happening that will make it into the news, that'll put pressure on governments. A SUS-sponsored program, early results in Rio. That would, the Brazilians would be interested in that. So I just think if we can leave here with some energy and a commitment to getting together in another year and presenting where we are with what we've done, it would be a great step forward.
You want to take one more question and then we'll wrap up? Or is there any other question in the audience? Oh, yeah. Alana? Oh. We make Lana work hard around here, right? She's getting her steps up at the same time.
Hello, excellent conversation. I am from Croatia and I actually work in a hospital which is a special hospital for medical rehabilitation. And we also have a huge cardiac rehabilitation program. I agree with the majority that has been said here. Cardiac rehabilitation still isn't, as you've said, a priority thing around the world, although it should be. And we actually should be forcing our governments with DALIs and QALIs, which are really qualitative and quantitative markers of that we can present to them and show just how efficient cardiac rehabilitation is for the people who are still working and still have many years to work and many years to support the economy, which is always important to every government. But it's not just about the money, it's about the patient. And we all should actually focus on prevention. And prevention is always something that gets put under the carpet, which is wrong. It should be the top priority. And yet so many cardiologists don't do other than lipids and maybe hypertension, but that's just the tip of the iceberg when it comes to prevention. We should be developing multi-level comprehensive programs from governments, from local communities, from education to cardiologists to encompass such a wide spectrum of what rehabilitation and cardiovascular prevention encompasses. And I'm very thankful that you started this topic and this conversation. So it's a very good thing. And hopefully on the next ESC, the stage is definitely going to be a much bigger when it comes to cardiac rehabilitation. I hope this is the incentive for that.
I think those are really great comments and couldn't agree more. And, you know, I think that's why it's important for an organisation like the World Heart Federation to get behind something like this. So couldn't agree more. I think we got time, just one wrap-up question from each of our panellists. Sid, what do you think?
I'd like to hear, at least one final statement from each of you.
So one commitment we could ask each member of the World Heart Federation to take forward. That's your challenge.
I guess I'll start. I think the World Heart Federation is already doing this in many, many respects, but I think we need to work with the governments more to prioritize cardiac rehabilitation, to have it written in national policies. I guess it's in strategy, just like what happened in Ireland, and this would be a great case study, I guess, to present to the rest of the world. But at the same time, in the national budget, because we need to have a dedicated funding and appropriate resourcing if you want cardiac rehab to be a standard and not a nice to have.
Yeah, I mean, I agree. Abraham, one suggestion for the World Heart Federation to take to its members?
I think it's probably to look at initiatives to build capacity. And I think from the discussion that's had, it's also building capacity not only among healthcare providers, but also empowering patients, working with patient support groups that cardiac rehab is something, it's their right, and that they need to be able to access it.
Yeah, okay. I mean, I think in a lot of countries, having the brand, having World Heart Federation saying this is something that's important, I think is powerful in itself. But Irene, for you?
Similar to Dion, I mean, my call to action would be really take this to the people who make decisions in your country, show them your national data, ensure you're collecting your data most importantly, and really emphasize the message that cardiac rehabilitation will save money, will improve quality of life, and all the other benefits that we know of.
Over to you, Sid. Beautiful answers, I think, from our panelists here.
I support all three. I think my feeling is that we need to take this effort forward. I'm not happy with writing a paper. I'd like to see us doing something and getting back together again. And if it has to be Rio, I'll put up with that.
We could go to Croatia. I mean, I don't mind that.
I'll go to Croatia.
We go to Croatia in 27. Lana? No?
Well, I think
okay,
we're
I'll
hearing
leave it to
from
you to
Lana.
wrap it up, Sid.
I've heard from Lana that they're complaining there's a radical group over here that's causing some problems, so we have to be careful they don't throw us out. But I want to thank all of you for attending, and I hope we can get together and move this ball forward. It will do patients a great service if we do.
And I think just from me, thank you to you, Sid. Thank you to David Wood and the World Heart Federation. And I think we've got 23 or 22 people on our writing group. To everyone that helped bring this together. Actually, we've worked really hard with Lana. We are the fastest ever group to produce a roadmap, and the board is aware of that. But thank you to Irene, Dion, and Abraham. And I think that's over and out from us. Thanks for being here.